Hello and welcome back. Good night, and I hope that you are having a good day so far and are ready to listen to one more presentation, and of course are ready to ask your questions, because I'm not sure if you are aware, this is our final webinar this year. And this topic is definitely interesting one. And actually, Dr. Ksenia, before we started, mentioned that it's kind of a miracle story here as well.
Yeah, promise that it's miracle story.
Exactly. So I'm glad that we will have a chance to get to know this story. As you know, we are focusing on success stories, and this is definitely an inspiring one. So thank you so much. Dr. Ksenia Khazhylenko is with us, as you can see her right here. And if you have had a chance, you know that she was here before, and I'm very happy that you are back with more interesting story. And how are you feeling? Hope you had a good day, and it's still busy at the clinic, I guess, right? Every day nowadays.
Yeah, every day. No, yeah. Any celebration don't influence on our schedule all the time.
I think that still it's great to hear, and I know that people are coming into the clinics, and of course, even if it's getting more this time of year when we have Christmas, so we are much more busier, but still, of course, you are definitely working and doing your best to help our patients, and I'm glad that you are here and helping out as well.
Maybe for some patient it's time for miracle.
Exactly. So, of course, we definitely want to hear those stories, those incredible stories. And let me just mention that, as I mentioned, this is our final webinar this year. But of course, don't worry, we will be back in January. You will be, of course, you can go to our YouTube, or sorry, you can go to our Instagram or Facebook, and you'll know that there will be some more events coming up. But also, I want to mention that, as probably you know, my evidence is a part of European Fertility Society, and actually tomorrow is the first birthday when it comes to European Fertility Society. So we've been here for a year. And it's amazing that we are still here and we are planning so many things. And if you had been able to follow us, you know that there are some other webinars in English, but of course there are some webinars in Italian and Spanish ones. And I can tell you that there will be some other ones as well. So we are very proud that we are able to help out the patients that speak many different languages. And I know that it's been helpful for you. So thank you so much for coming in. And of course, thank you so much for taking part in this, and of course for asking your questions, because as you know, we are here for you, and we are definitely happy that we are able to do this kind of job as well. And well, I guess it is time to start our presentation. As you know, we will talk about premature ovarian failure, and I know that Ksenia has amazing presentation. So let's not wait anymore. And remember, if you have questions, this is your time. You can go ahead, type those in the chat section. Now you can do it later on.
Thank
and
you.
Let's go ahead, okay?
Thank you, Carolina.
Thank you so much
for presentation, for introduction me. Yeah, and let's start my presentation. Today I would like to present you really up to me it's incredible clinical case, and up to me it's very inspiring, and I think it will be the same for not just for patient and also for doctors, because we all need a miracle, not just before Christmas, but all the time. Generally, premature ovarian insufficiency or failure, it's not very common condition, and generally it's approximately just about 1% of all women suffer from this condition. But if you are a reproductologist, a fertility specialist, sometimes you think that half of your patients have this condition, because it's a lot of women with these problems in our appointment, and all of them are disappointed and worried and afraid. And doctors, fertility specialists have also the problem with the patient, with this consultation, and they're quite exhausted, because it's very difficult to bring all the time bad news and to give unfavorable prognosis. So really we need miracles sometimes, and I hope this my case will be such miracle. And let's start. And this is about patient with sorry, yeah, this is my slide. Yeah, and this is my patient. She was young enough when she came to me firstly. She was 33 years old, and as you can see, she was very thin. And please keep in mind this point. A bit later, I'm back to this point. She was pregnant. She had 2 healthy babies, and it was normal natural conception. But now she's planning pregnancy. She was at time planning pregnancy, but she don't have menstrual bleeding during last half an hour. And very bad sign, she had hot flashes. So she came to doctor, I think just because of flashes, because she was very busy all the time. She worked a lot. She had small babies. She had a lot of problems, a lot of stress. She, I think, don't have enough time just to eat even. But hot flashes afraid her so much, and she came to me. And when she came, I asked her about starting of menstrual bleeding. It was absolutely normal, regular, normal during all her life. And just last a bit more than half year, they changed. Firstly, there was a prolonged cycle, and then she stopped absolutely during last 6 months. And we provided hormonal test, and unfortunately, our suggestion on this condition was confirmed by test result. As you can see, that it was a very high level of gonadotropins and very low AMH level. And also on ultrasound, I didn't see any antral follicles. She had a bit high level of TTH. And we check her gonadotropins next month, and also they were increased. So the conclusion, of course, was premature ovarian insufficiency. And what to do? She was disappointed, but all the time when we met the patient with premature ovarian insufficiency or failure, we have to try understand why. Firstly, what do we know? We know that this condition when ovarian function decrease in age less than 40 years old, and it characterized by a changing of menstrual function and raised of gonadotropin levels and very low level of estradiol. We usually talk that the reason can be different. It's iatrogenic reasons. So in women after different kind of surgery on ovaries and uterine tubes, also in women after chemotherapy and different type of aggressive therapy. It can be genetic causes, it can be autoimmunity, infection. But if you see on this my slide, you can see that almost half of all cases of premature ovarian failure cannot be explained any additional conditions, so they are idiopathic. And that was in our patient. And we just need to provide some test, hoping that we find the reason of this condition. And in my patient, we provide the same. We do even karyotype, despite on it was her wishes to do this test, but also we provide FMR mutation and no any genetic problems found in this testing. But as you can see, we find some problems with thyroid function. It was a bit higher level of TTH and also very high level of antibodies to thyroperoxidase and normal prolactin level. And really association between thyroid dysfunction and ovarian insufficiency, it's very common. Literature data, regarding literature data, that approximately 20% of all these patients have this association. Does it mean that if we treat thyroid, if we normalize this function, so function of ovary became normal? Data is very conflicting, and unfortunately, mostly cases we don't have any normalization of ovarian function, but we should try. We should try, and we decided to prescribe artificial hormone therapy, replacement hormone therapy for my patient, and it was small dosage of estradiol and also micronized progesterone. I want to emphasize that usually we start with from very low level of estradiol, and if a patient feels good, no need to increase this dosage, because we are talking about quite long period of time for replacement hormone therapy. And also we add levothyroxine regarding the thyroid dysfunction. And I prescribe her to come to me after 6 months, but 4 months later she came with positive pregnancy test, and it was normal pregnancy, it was normal birth and healthy baby, and she breastfed her during long time. But it's not not the miracle. Really, it's great news. But we know that the patient with premature ovarian insufficiency can become pregnant, and we need to keep in mind this all the time when we talk with the patient, because even when they have menstrual disturbance or amenorrhea, they can become pregnant, and almost 5-10% of them have this chance. So it's not my miracle when I wanted to present you, but miracle happens a bit later, when she came to me 2 years after delivery, and on those times she was 36. She breastfeeded more than 1 year. And now on those times she have already stopped. Her BMI on those time was normal, and she have regular menstrual cycle during last 1 year. It was very wow to me, and we check gonadotropin levels, and FSH, LH, as you can see, estradiol was normal, TTH was normal, and the great news was that AMH level was also normal, and on ultrasound examination I saw normal number of antral follicles, and I asked to me, is it really possible? But it was possible because she was in front of me, she was alive, and yeah, it was possible. And I cannot understand the reason for this changes. Maybe they was first her condition was because of stress, because we know that almost half of all patients with premature ovarian insufficiency had a history of anxiety, depression, and negative emotions. So it's really can be the problem like the triggering for this condition. And I surfed internet. In special literature. I found just one case. It was almost 20 years ago. And it was very similar case with a young patient who had the same problem, the same condition, but after spontaneous conception, after delivery, she had remission, and on the time of publication, the remission was almost 10 years. About my patient now, her remission are almost 5 years, and she menstruates. She has normal menstrual bleeding. She has normal gonadotrophin levels. She has normal ovarian function, and she is a healthy woman. And it's really a miracle, but I wanted to understand why. But as I have already mentioned, almost half of all cases premature ovarian insufficiency are unexplained. So when we cannot explain the reason, we cannot to make a prognosis, and also we cannot understand why and what to be in the future. So I suspect maybe weight loss was the triggering for this condition, because, as I have already mentioned, her body mass index decreased during not very long time on 11 kilo for her BMI. It's 20%. It's very high. It's very stressful. And I don't know what was the first. Stress was the first, and then she lose weight or losing weight. It was stressful condition and like triggering for ovarian insufficiency. But it's well known that stress may damage ovarian function, because it's cortisol influence on down regulation of this function, and we know that it's theoretically it can be triggering for ovarian insufficiency. And when we try to do prognosis on this patient, because if you remember, she came to me with very, very bad situation, with without menstruation, with high level of gonadotropies, with hot flashes. It was really symptoms of menopause. And I couldn't make any prognosis because we really in all these patients, we don't know what is the rest of the follicles. It's not a secret that there are different follicles in the ovaries, and we can assess just part of them, but we cannot assess so-called primordial follicles and preantral follicles, primary and secondary preantral follicles, and also small antral follicles. We cannot assess them because when we provide routine assessment of ovarian reserve, we use two standard markers, AMH level and also antral follicle count. But antral follicle count, when we count the follicles by ultrasound examination, we can count just follicles size from 2 millimeters and more, because less than 2 millimeters we cannot see physically. So, but small preantral and primordial follicles are very, very small, and we cannot assess them without morphological, without biopsy of ovaries and without morphological examination. We could just count those follicles which we could count. And also when we assess AMH level, it's very important to understand that AMH produced not by all follicles, but just follicles starting from small preantral size and finishing antral and even big antral follicle do not produce AMH. It means that the same, that primordial and small preantral follicles don't produce AMH, and when we assess this level, we can miss this potential. So maybe in this situation, like with my patient, some stress induce like break in follicular genesis on some period of time. I suspect this period of time was for her nature, it was like dangerous for menstruation, for pregnancy, for giving birth. And the nature decided to just make a break. And then after normalizing all condition and body mass index, and after decreasing level of stress, situation change absolutely. And it's a good use. And my conclusion from this case is that things not always the same they look like, and this is really miracle. And I think we all need this miracle, not just before Christmas, but all the time in our work. And I wish you this miracle, not just Christmas, but during all your life, work, treatment, I don't know. And in the end, I want to just show, this is my clinic in Kyiv, Ukraine, and this is my favorite city, Kyiv. And I thank you for your attention, and I'm ready for your questions, and I will be glad to answer your question if you have them. And Carolina will help me to translate it,
Definitely.
to show your question if they are. Yeah.
Thank you so much indeed. And thank you for sharing. This is definitely not a typical story. And definitely it's amazing to see that such miracles, right, happen, because, yeah, it's definitely something that can be inspiring for anyone watching, for sure. And I would say that it's something like, never lose your hope, because this is amazing. And sometimes when we see that it's not going to like work, and then some things like this happen. So amazing. Thank you so much for sharing this with us.
Thank you. Thank you. I didn't know that is the last webinar before Christmas. Really, I just asked you today, and I prepared this case just because I wanted to prepare the.
And we are definitely glad. So yeah, trust me, the Dr. Ksenia didn't know that it's our final one before we have our Christmas break. So thanks so much. It just happened to be perfect for sure. Thank you. And as you know, it is time for your questions. So if you have some more, go ahead, type those in. Of course, there are some. So I guess we can have a look, and let's start with the first that we got. It's about the case as well. Can low BMI cause amenorrhea? Also is in this first case.
Yeah, sure. I think the problem was in the very low BMI, and generally about amenorrhea, because we are talking now about premature ovarian insufficiency. It's a bit different, and you saw that gonadotrophin levels was very high, and also I didn't see any antral follicles in ultrasound. It's very important. It's just not just amenorrhea, but generally, yeah. There is even some special term in medical practice, so-called amenorrhea of the war. It's period of time, and very difficult time, when women don't have to eat enough, and when they lose weight, it can be dangerous, because regulation of menstrual function is from our cortex, from the brain, and during stressful time, it's not just BMI about, it's any stress can be the reason for amenorrhea. But it's not obligatory amenorrhea with ovarian insufficiency. It can be just amenorrhea, and after when the stress will stop, menstrual function can recover.
Thank you so much indeed. And that is why it's so important to also deal with stress and try to work it out somehow, because then it can have a great impact after all, right? So we should never forget about that. So thank you so much indeed for your question, Ilona. And now let me show you the next question, a bit of a longer question. This is a question from Shilpi. So welcome back. And the question is, I'm 40, and in my last IVF cycle, we got 2 embryos from 7 eggs. Is that a good number of eggs for my age? Am I at risk for ovarian failure? I am also concerned with other blockages in my body. Before my IVF, I went for laparoscopy. It was my understanding that the doctor would clear my any endometriosis and unblock my fallopian tubes, but doesn't seem he did that, as my report still says closed tubes. Is that not standard procedure in laparoscopy to help the body to conceive naturally? Does your clinic do such surgeries for unblocking tubes? Thank you so much. I have no children and I feel I am running out of time.
Thank you for the questions. Yes, when we are talking, the matter is that when we are talking about enough eggs, it's very difficult question how many eggs it's enough for the process. Unfortunately, for older age, we need more and more eggs, but ovaries cannot produce not more, but even middle number of the eggs. And if we are talking just about 7 eggs in 40 years, yeah, it's good result generally, but it can be not good result to for our aim to get not just the eggs, but take home baby. Yeah, if you remember. So according our task, this number can be not enough, but it's not a sign for the stopping of ovarian function. I think it's a bit it's not correct to say that it's a bad sign. And 7x means that at least some years you have for normal ovarian function, for producing of the eggs, for menstrual function. But when we are talking about IVF, it's absolutely different. It's absolutely different. And even in case like a patient with premature ovarian insufficiency, sometimes there is the situation when the patient have more chance on natural conception than on IVF result, because for IVF we need more eggs than for natural conception. It's paradox of reproductive medicine, because for natural conception we need just 1, but for like in your question, sometimes we need much more to get a result. But sometimes some of patients really, I don't know, it's maybe about good luck, I don't know, but sometimes some patients have a good result, euploid embryos and pregnancy and live birth, just in 1 or 2 or 3 eggs in 40 years. It's not about medicine. The second question about laparoscopy. No, in Ukraine we don't have laparoscopy like routine procedure with blocked tubes. We don't use this procedure just for the checking the tubes and for trying to unblock them, because success of this procedure is quite low, unfortunately. So we use laparoscopy just when we need to do something else. For example, when we need to remove some myomas, or when endometriosis in the ovary are very big, but we operate endometriomas, not very common. So no, it's not routine procedure. This is my answer. I think it's all answer for your question. I think if no, please add something else, because a bit yeah, maybe I missed something.
Thank you so much, and I believe it was of course helpful. So thank you, Sophie, for sharing. I hope that helped. And if you have anything else you would like to add, you know what to do. Okay, thank you so much indeed. And of course, there's a thank you from Shelby for you right here. Okay, let's have a look. Some more questions are coming in. And next question is from Linda. Thank you so much for this hopeful story. To what do you attribute the increase in AMH and lowering FSH? To the hormone therapy or less stress and weight gain?
Oh, increase, yeah. When we, if we are talking about just this case, I think she just works with her stress. But generally, it's very common question what to do to decrease FSH and increase AMH. Unfortunately, I don't have any recipes for this treatment. Sometimes we cannot increase AMH. It's 100%, and all our attempts to do this is just about adjuvant, so-called adjuvant therapy, when we use vitamins, when we use dehydroepiandrosterone and testosterone, and this is just trying, and they have up to me very small effect. But I don't know, some patients, when they a bit improve folliculogenesis, and when we take more oocytes when we thought previously, maybe it due to this adjuvant therapy, but maybe it's just due to some changing in lifestyle. I believe in lifestyle much more than in adjuvant therapy. It's honest. So sometimes, about question about FSH, we cannot decrease very high level of FSH when it is more than 20 units per milliliter. But sometimes if this level increase a bit and we start the stimulation, if we have some even small number of antral follicles, 3 or 4, and a bit higher level FSH, we can do use some options like using estradiol before starting of stimulation. But in some cases, we need to use down regulation, but by agonist gonadotropin releasing hormones like differylin or decapeptyl. But we need to be very, very careful with this second option, because sometimes after using of this is effective options, but sometimes after using of them, we can not take answer on ovarian stimulation. So using estradiol, it's more less danger, but also less effective. So, but we need talking just about not very high level of FSH, but not about AMH increasing. Sorry.
Thank you so much. And thank you for that question. As you mentioned, this is something that definitely comes up a lot. And obviously, I think it's a question that we would like to get some more evidence on, and just that this is working, but unfortunately this is not how it all works. And actually Linda has added one more thing, so let me just show you here. Thank you so much. How did your patient control her stress, and is she still in hormone therapy?
My patient, no, thank you, no, she haven't taken any medication, and even thyroid function normalized after delivery. So for her, I think delivery, breastfeeding, was maybe like therapy to control stress. I think maybe we off one stress to other. I don't know. But if you remember, her body mass index increase on from 17 till 20. So it means almost 15-20%. And I think it was enough to decrease stress level, and also breastfeeding. Breastfeeding is very important in this line. But generally, not about this patient, but generally how to control stress. Difficult question, because to control, we need just general recommendation to sleep enough, to have some physical activity, to eat healthy food, to use some vitamins. That's all. That's general. To stop smoking if you use, to stop caffeine intake if it's more than normally. So it's just general recommendation, but they work. This recommendation work not in the same way, and even sometimes better than adjuvant therapy.
Thank you so much. Thank you so much, Linda, for your follow-up. And actually, as we are talking about stress, actually there is one more question. So let me go straight to this one. And of course, we will go back to the previous ones. So is there some kind of a stress relief therapy for IVF patients in Ukraine? What is proposed in general?
Stress relief therapy. So usually we start when we start IVF program, we usually recommend for any patient, for any situation, even without of these severe factors. We propose to make appointment with psychologist. So then patient should decide, is it okay for her or no? Do she or her partner or couple needs this support during treatment? And if they choose this support, working together with psychologists is very, very helpful for the result of IVF program. It's really, I really believe in this work together. But some patients refuse. They don't need any support. That they want to do something to, I don't know the reason. But sometimes some of my colleague psychologists could call me and say that those patients need not just individual or group work, but some of patients need also medication. And this kind of medication, it's different specialists who need to try and to treat this patient before program, and not all medication are compatible with planning of pregnancy. Sometimes we need to make a break. But anyway, the result, when we can do something to improve the result, to control stress firstly, and the second one to improve this IVF treatment, we do this.
Thank you so much again, Elena, for your Definitely important question. This is something that I think
Yeah,
that
it's
sometimes
very
it's omitted
important.
a bit.
Mhm.
Exactly. Yeah, sometimes we are focusing, of course, on that
Of
medical.
medical condition, just medical problem, but it's not. It's very important part of the treatment. According that, despite on all our success, the success of program IVF, not more than 50%. It means that half of the patient don't become pregnant during first pregnancy. And also we have a group of severe patients with recurrent lactation failure, with the same ovarian insufficiency, and all of these patients need supporting during the treatment.
Thank you so much. I'm glad that we are able to also mention that and talk about it. It's important, as you said. And I guess there are like 2 questions we will be finishing. So, of course, if you have more, you know what to do. Don't hesitate. And let's have a look. Of course, there is another question and a bit of a backstory. I'm 40, my AMH 0.24, my AFH is 8. I made an IVF cycle with hormones, but at the same time, I made a restrictive calories diet because my doctor said that I need to lose 2 kilograms. I only have 1 egg with bad quality. Is it possible that this response was because of the restricted diet?
I'm sorry, I cannot understand. Sorry for the. I cannot understand what the first BMI. Why the doctor said that you need to lose. You need to lose this weight during program, not before program?
Yeah, if you can, Carla, if you can let us know, right? So
Because
we can make sure.
During the program. No, up to me, it's not a good idea to lose weight during stimulation. All the time, well, we need decrease BMI. We have to work before starting of the stimulation, because losing weight is stressful. It's stressful for the ovaries. And ovary can be sensitive for high cortisol level when we lose the weight. And but in case when a woman 40 years old with very low AMH level take just one oocyte, it can be despite on this situation with losing weight. I don't know. We don't have control group here. You are, but without losing weight. In this case, we would know will be answer the same or different. But I think it's really can be not because of the losing weight. But anyway, on next time when we decided to provide ovarian stimulation, will be better idea to share these 2 processes. Up to me.
Thank you so much. And possibly Carla is typing in, so let's give it a minute, of course, and I will get back to this question
Okay.
when we have some follow-ups. Of course, I think we might have. So let's get going with the next one. Okay. In the meantime, here it is, a bit of a longer question from Christine. Thank you so much for taking the time to speak today. I would love your feedback on my situation. In my case, I stopped having menses for 3 months, then it returned 1 month and disappeared again. My BMI is a bit high. Would you recommend lowering my BMI and continuing eating for fertility and taking supplements before looking into IVF? Or would it be best to look into medicated assisted fertility first to assist with hormone levels?
Thank you for your questions. And I all the time I say my patient that any changes in BMI can influence on ovarian function. Usually we are talking about normal BMI when it from 20 to 25. It's ideal, but it's not always real. And this association, which was in my my instance today, it's a unique situation. I said you first in the start of my presentation that it was a unique case, and it was unique not just my practice, but also I show you the publication, and I found just one case, similar case with recovery of the ovaries, so-called, and it means that all the time when we have premature ovarian insufficiency or failure, and if you have any association, thyroid dysfunction, changed BMI, low or very high, something else what we can change, up to me will be better to change, because we never know what is the reason. Of course, if we are about genetic factors, about surgery, this recommendation don't work. So if ovarian reserve is very, very low after surgery of endometriosis, the matter is not in BMI and not in thyroid. But if there is idiopathic, so-called, ovarian insufficiency without any explanation, it means that any changes in your condition, in your health can be helpful for the ovarian function. It can be helpful or not, but we should try. It's up to me. So your second question is that BMI, for fertility. Taking supplements, it's a good idea anyway. But before, before starting medically assisted fertility, will be better to lose weight. Yeah, up to me. You should try. You should try. Maybe it can be helpful. Because any other ideas what to do in these cases, unfortunately, we don't know.
Thank you so much, Christine, for sharing, and thank you, Ksenia, as always. And there's a thanks from Christine for you right here as well. Okay, thank you. Okay, now we will go back to the question from Carla. Okay, so the previous patient just had added some additional information. So let me just, it's right here. So my BMI is normal, but the doctor said it was better to lose 2 kilograms. So during the stimulation, I had the diet and I lost 3 kilograms in 1 week. When the result was 2 eggs, but only one with 19 millimeters, it came to my mind that maybe the diet could affect that.
I don't know. Yeah, that's the matter is that the evidence-based medicine should make evidence according to the situation with case and with control. So in this case, we don't have the control. Yeah. We don't know. It's just our fantasy. What will be if we not do or not do something. So in your case, I think lose 3 kilo in normal BMI, it's stressful, 100%. The second point, and during ovarian stimulation, we usually recommend a diet with quite high level of proteins. And if you, I think, if I get, when you lose the weight, you eat not enough proteins. Yeah, you exclude not just carbons, and this is disproportions between what you need can be crucial, really. But anyway, in the start of stimulation, you have not ideal prognosis, but maybe, yes, maybe this situation influence, I don't know.
Of course, this is, thank you so much for your follow-up, Carla, and thank you, Dr. Ksenia, for helping.
Anyway, it's stressful. I think
it's never easy. Yeah? It's not like a yes or no kind of question, I'm afraid, right?
Yeah,
so this is the issue here. But thank you so much. And sorry, one more question from Shilpi, actually. Another follow-up from Shilpi. So here, small follow-up question. Is mini IVF recommended for older women? Shilpi mentioned she's 40. Does mini IVF always lead to better quality eggs? This procedure is less stressful than normal IVF, isn't it?
If we are talking about mini IVF, like mild stimulation, because there is 2 points. Mild stimulation for you if you could write yes for this question, some I will be.
Yeah, Shilpi, if you can answer if this is
about
mild stimulation mean exactly, so we can make sure, and possibly she is typing, so let's give it a second and make sure.
So if you are talking about mild stimulation, so now
mild stimulation.
Yeah. So now we don't use usually very high dosage. Some doctors use, but generally, mostly of all clinic use so-called standard stimulation with highest dosage of FSH, not more than 300 units per day. So it means, but mild stimulation means not more than 225 units. For old age, it can be crucial. Up to me, it's not a good idea to use this stimulation for age after 35, especially for low ovarian reserve. They need higher dosage. But anyway, mild stimulation, it's not very popular strategy nowadays. Because the aim of any IVF program to take not just oocyte but take baby, and it means that during stimulation, the aim of stimulation should be to take enough oocyte to take a baby. But in case of mild stimulation, up to me, the aim is just take some small number of oocyte and to be so-called patient-friendly. But it's not about live birth. It's not about taking a baby. Yeah. And any publication, I don't know the publication about better result on this group of patients with mild stimulation in age after 35. Sorry, it's not a good idea.
Okay, thank you for the clarification. Silpi, thank you for your question. And let's have a look. Might be our final question for today. But of course, if you have more, you can do it now. But as always, I want to mention that if you wish, there is also a possibility for you to get in touch with Dr. Ksenia, her team at IVMED, and I'm sure they will be more than happy to help you out with any questions that you might have. And there's a thank you from Shilpi here. And the question is right here. I think I hope that I understand it correctly. So this is the question. I'm 43 and I have done cut, tie and burn and having everything normal with my body. Can I get it reversed or I can only do IVF?
Doing IVF in advanced maternal age, it's not just about making IVF. It's about the time. It depends on what you wish. Sometimes some patients, when they understand that they're healthy, have normal ovarian reserves, have don't have any problems with tubes, with the sperm of the husband, they can wait. The problem is that in age after 40, the effectiveness of the IVF program is quite low. But possibility of natural conception can be not more than not less, sorry, than IVF result in some patients, especially after 42, 43 years old. So some patients in 40 years come to me and say me we choose to wait during sometimes year or two. Or some of them say me that we don't have pregnancy during, I don't know, 6 months, and we don't want to wait. We want to provide IVF program. So any time in this situation, I need to explain. I need to explain the choice on pregnancy, on natural conception, on IVF program. In both cases, after 40 years, it's quite low. And if you understand this, and if you choose IVF after a short period of waiting, it's your right. But if you prefer to continue wait, it's also your right and your decision.
Of course. Thank you so much indeed. And as I mentioned, that possibly was our final question.
Yeah.
So thank you so much, everyone, for joining in, for your questions. I always think that it's always amazing that you are here and you are asking, because of course that this is a webinar, so we cannot fix, let's say, your problems. However, I think that we, like all the doctors, can maybe give you some advice, and maybe that way you can actually get something done and maybe change something as well. So thank you so much, Dr. Ksenia, as well. It's been great to have you here, and thank you for not only for this webinar, for the previous ones. It's always a pleasure to have you here. And as I mentioned, this is our final webinar this year, but of course, don't worry, we'll be back in January, mid of January. We don't have the date yet, but don't worry, there will be some more webinars, and I'm sure Dr. Ksenia will be back, right? So, so we will see each other very soon. And now I can only wish you a happy Christmas, and I hope that you will get your miracle sooner rather than later. And as always, we keep fingers crossed, because of course we are here to support you. And I always love that sometimes whenever I receive some sort of email or message that something happened, and of course you got that miracle, it was possible, it's always amazing. And I do wish to everyone to get that for sure. Thank you so much, everyone. Thank you everyone. Also here they are writing all the thank yous right here. So thank you so
Carolina.
much.
Thank you, all of us. Thank you. I wish you, of course, I wish you happy Christmas, and of course I wish you the miracle in your everyday life. And thank you for this possibility to be together with you. Thank you, and bye-bye, and Happy New Year.
Exactly. Thank you so much. As I mentioned, we will see each other next year. But of course, remember that there are plenty of webinars. You can go to my IV Fences and simply have a look at this webinar, but also all the previous ones. So there is plenty of webinars. You know, there are over 400 webinars, 415 if I'm not wrong. So plenty of things to check, plenty of things to find out maybe as well. And yeah, happy Christmas. See you next year. And take very good care of yourselves during that time as well. Thank you, and take care. See you soon. Bye.
See you.